Hi, everybody. Welcome. Good morning. My name is Courtney Petruik. I'm with the University of Calgary. You'll see three other people there on the list there, but they're not here today. It's mostly my Katrina Milaney is my supervisor, Helen Hagos, and Wai-San-Cheong are both research assistants, and I am a new postdoctoral scholar with Katrina Milaney. The study we're doing today is called It's the Best Kind of Care, Even for the Tidy Bungalow Folks, and you'll see kind of why it's there as we go. So first, I just wanted to talk a little bit about why I do this research. I'm a white researcher who lives, works, and plays in the city known as Calgary, which before colonization was the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. I research homelessness in this land with lived experience in that area, with still much to learn. It's my hope that through my research and how I live, I can continue to learn and teach in ways that progress equity across all equity-deserving groups. One thing I want to say before I get into my presentation is that this is day 2, and one of the things about presenting on day 2 is that you learn so much from day 1, and your slides are already uploaded. So there's a little bit of winging it, there's a little bit of learnings that I'm incorporating last minute, but I feel like that's just kind of the nature of this type of work, and so I hope you can all bear with me, and hopefully we can kind of have a discussion at the end and progress each other in our learnings. So I'm going to start with a little bit of a lesson. I wasn't sure whether I was going to include this or not because it's a Canadian conference, but I learned this morning that people are coming from all different places, different countries, and so I'm going to give you a little crash course on the Canadian healthcare system. My students would be rolling their eyes right now. So our healthcare system, as you may or may not know, is publicly delivered, and that means that we have insurance plans that aim to remove financial barriers to healthcare services. The healthcare system is meant to be universal, which means that all Canadians and permanent residents can apply for public health insurance. In theory, this system aims to make services available to all Canadians, but for many Canadians, while the services may be available, accessing healthcare is much more complicated. Distinguishing between availability of services and access to services helps us understand that being permitted to services does not always translate into the ability to use services, or that the services meet the needs of the people. For people experiencing homelessness, accessing healthcare is more challenging, and these challenges are made worse when the person has a life-limiting illness. So people who are vulnerably housed, as you probably all know, much better than us researchers, have a higher risk of chronic illness and higher mortality rates than the general population. People experiencing homelessness often have life-limiting illnesses that go untreated or undiagnosed. Because they're unable to access healthcare or avoid it altogether, and because they often feel like the system isn't made for them. Absence of education around homelessness for healthcare and a lack of acknowledgement of or repercussions for mistreating this population are problems in our Canadian healthcare system. Multiple studies show that people experiencing homelessness who use substances, for example, were rejected from accessing services because of the absence of things like a harm reduction approach. The way that the healthcare system is set up excludes people experiencing homelessness from palliative and end-of-life care services. For instance, healthcare services and systems often have rules like not being able to use substances while in care. Another example of the rigidity of the current system is the lack of openness to managing missed appointments, for example, or follow-ups. These issues create even more barriers for people experiencing homelessness and creates ongoing negative effects like disconnecting people from care completely. Other challenges often include lack of financial resources for costs of medications, even though we have universal coverage, and transportation to and from medical appointments. Also, ethical and legal challenges when there's no surrogate to decision making. And of course, unmet respect of patient wishes at end of life. You also have the intersecting racialized groups that face many oppressions in addition to the above issues. So there are lots of barrier-related studies and barrier-related works out there that talk about challenges, and many of you are doing the good work despite the challenges. So we have these political constraints, especially in Alberta. We have systemic constraints. We have individual constraints, and despite those things, people are doing really good work out there. So this project is where we recognize kind of the need to know what that work looks like. So while there's no universally accepted term around health equity, it typically refers to having the personal agency and fair access to resources and opportunities needed to achieve the best possible physical, emotional, and social well-being. Further, the term palliative equity has emerged in recent decades that moves this definition into the end-of-life care space. While definitions are important, they can be vague and difficult to implement in real-world situations. So teams across Canada, much like yourselves, have done really important work on the front lines trying to deliver palliative care to people experiencing homelessness. So there's a movement you might have heard about, probably you have, a palliative equity movement, and these teams are kind of often located just outside the mainstream health system. So some places in Canada, they have adjacent funding or they have matched funding, but in many places they start out without any public funding, despite the publicly delivered healthcare system. So there's specialized teams that operate in ways that promote what they refer to as equitable palliative care. It's because of the broad reach of the health and palliative equity movements that we felt it's time to understand from the ground how equitable care looks in practice and how service providers that specialize in this practice and the people they support talk about and identify as equitable care. So there are two research questions that we explored. They're pretty simple, and again, this is one of my, oh gosh, I should have just changed that. So I have this as service users. Now I want it to be service recipients. So this language is going to be changing as we go. So I'm learning things, so bear with me. It says service users, so I'm going to try to say service recipients. I'm not even sure if that's something that people will agree with or that I'll stick with, but I feel like it's better than users because I feel like language is really important. And so I'm going to call them service recipients for this presentation instead of service users. So how do service recipients and service providers talk about equitable healthcare for people experiencing homelessness with life-limiting illness? And the second one is, what types of equitable care work have service recipients and providers witnessed being carried out? Pretty simple, kind of. So we did a research ethics application, which that's an entire study in and of itself, getting through the research ethics process with vulnerably housed individuals. And it got approved in March 2023. So that I felt like I wanted to bill it because it took us forever to get the research approved. Recruitment was through a local nonprofit community-based palliative and end-of-life care team in Calgary. And we did one-on-one interviews with service recipients of that team, as well as service providers from that team, and using a snowball approach, which just means basically, hey, I'm having an interview with you. Do you know anybody that might also identify as delivering equitable care? Who might we interview? And then also in terms of the service recipients, do you know anybody that might want to talk to us in terms of your clients or anybody your clients know? They hand out my contact information or agree to be contacted, and that's how we did our sampling. The analysis was a theming analysis. So what we did was just familiarize ourselves with the interview transcripts. We coded the data, so that just means kind of going through line by line to figure out what people said, kind of in chunks, generated themes from the codes, went back and forth with service providers and where we could, service recipients, but often they weren't well enough or kind of didn't really care too much to talk about the codes and the theming part, but tried to have conversations where we could, and then determine the significance of the themes in the context of what's called the ETR Health Equity Framework. So this framework was something that we chose because it acknowledged some of the issues with kind of wide range theories of health equity, social determinants of health, identifying that some of the issues with those large frameworks are kind of removed from the applied situations or the practical knowledge. And so we liked that because that's what we were kind of doing. We were trying to kind of bypass these like buzzword, big theoretical ideas and try and create common language around what's actually being done in kind of a descriptive way. And so these authors, the ETR stands for Education, Training, and Research, but it's normally applied to youth populations in various socially marginalized groups. So it's never been applied to, as far as we know, people experiencing homelessness with life-limiting illness, so in like the palliative end-of-life care space. So we're trying to kind of look at that and see how our interviews and the things that people say kind of map on to the different areas of the framework. So the four areas, it's a three main principles, but we're going to be talking about the second principle, which is just the 4 areas. And so relationships and networks, systems of power, individual factors, and physiological pathways. So it's kind of what you would think. This framework is meant to kind of take out the individualized, responsibilized lens of how we often look at care. So rather than saying a person's responsible for their care because they're individually responsible for making their appointments or doing this or doing that, it kind of zooms out a little bit. So it does the same thing as you might have heard, like the social determinants of health, those kinds of things, but in a way that also incorporates a person's agency, as well as kind of like the last one, physiological pathways. We can't take away a person's, genetic predisposition for certain things. We can't take away an individual's personal circumstances or affinities towards this or that choice, those kinds of things. But what we have found in this situation or in this research is that most of, if not all, of the comments that came out from the 2 research questions are really securely handled in the relationships and networks swoosh, or the systems, that is an academic term, or the systems of power swoosh. It's the coffee. I had a coffee this morning, and I normally drink tea, so. All right. Oops. Okay. So there's 3 main themes that came out from the research, and as you can see, I circled the 2. I just have the image of the framework up at the top because they're the most aligned spheres of influence. So the 3 themes that came out were adapting to individual needs, service provider practice orientation, and having an engaged presence. And so one of the things that I wanted to add in here is that while we found that this was what the workers were saying and the service recipients were saying was really important to providing equitable care, the thing that I'm learning and was really that came through in my yesterday's sessions was that the shoulds are really high for the caseworkers and the care workers and the but we need also, I need to have like something else in here. I'm going to couch it in the research that talks about this, but supports for the workers, because individuals, like we're running into a crisis where the people that are caring for the people are now becoming a population of people that need to be cared for. And that's always been the case for caregivers, but now it's becoming even more so. So I just want to say that despite these themes, they look like shoulds, but that's not kind of what I'm getting at. I'm more describing the great work that everybody's already doing. And if that's something that we can take to continue to challenge those systems of power pieces, that's my main take home. So hopefully I can make that clear through what I'm talking about. All right, so first is adapting to individual needs. So there were 2 sub-things that came from this theme, flexibility and advocacy. So I'm not sure, can you guys read those quotes pretty okay? Okay, so we have the service recipients in red here, and then the service providers on the right. I'll just let you read those. So I just realized that there might not be people that read English very well, so I took a break, and now I'm going to read them. So look at me, just trying to adapt, guys. Flexibility. I've had so many problems with my phone lately that I put off a couple appointments. I'm going, how do I take the bus to get there? If somebody is there and helps me when I need it, then it's okay. So that was a service recipient. And then in the vein of flexibility and adapting to individual needs, the service provider said the principle should be to try and treat people where they are, unless that's impossible, and rarely is it impossible. So that, to me, is the biggest issue in healthcare right now, that we don't seem to understand that. Those who worked in the community for a long time recognize that providing that kind of care is the best kind of care, even for the tidy bungalow folks. So I thought that quote was really interesting, and the fact that the caseworkers and the physicians and the nurses and the people that I talk to are referring to these tidy bungalow folks, which I found out during the research that they're talking to people that this mainstream healthcare system is made for. The white middle-class individuals that can go home to their tidy bungalow with social supports and those kinds of things. And so you have the service recipients that they're working with that don't have the tidy bungalow to go back to. And so they kind of, in a way, are trying to make the argument that the people with the tidy bungalow folks can also benefit from equitable care. It's not just the people that require housing or have other social barriers in the way. And so in that comment right there, and I'm kind of going on a little bit of a tangent, but it kind of shows that the people that are delivering these services are also really adept at making an argument that the population that they're working for isn't argument enough to change the system. We have to also say it's good for everybody. I swear, look, it's a cost-effective thing. And so there's kind of another little nuance to that comment, which is why I created the title about that piece, because I feel like it's a really poignant statement about kind of the way things are, or the way the system is structured. So advocacy is the second piece. The team's care helped when I couldn't describe to my doctor in ways they got it that I was in pain and that the dose of pain medication wasn't enough. And then the service provider said, the hospitals can be challenging to communicate with. Things sometimes get dropped or lost, or our priorities in our health aren't always shared in the acute care setting, which in some respects is required. It's hard to ensure that equity follows people through all aspects of healthcare. They still have poor experiences with healthcare, so trying to be the advocate and the middleman in some of the interactions, I think, is how we support equity. So the participants spoke about having someone, or in the service provider experience, being someone who is able to help the person navigate their healthcare environment. For the service recipient, they did not describe themselves as an active substance user, but their tolerance for pain meds was such that the dosage they were given wasn't enough to curb the pain they were feeling, and their word was not enough to convince the physician to increase the dosage. So at end of life, that's problematic because then they're going to be suffering, whereas palliative care in and of itself is supposed to relieve suffering in all domains of a person's situation. It was not until the community palliative care team provider spoke up and explained the situation, advocating for them, that they're able to address the person's pain adequately. So both of these themes demonstrate the unpredictability of providing care and the need to adapt to the needs at hand. When applying this theme to the health equity framework, it bridges the systems of power and relationships and network spheres of influence. The advocacy component challenges the systems of power embedded in the healthcare system, and the flexibility component contributes to a stronger provider-patient relationship, which, in their case, claims that it influences equitable care positively. So the second one, the second theme is service provider practice orientation. So this one had 4 sub-themes. It had non-judgmental attitudes, maintaining reflexivity, and then the 2 sub-themes on the next page. And so the non-judgmental attitudes here, that we have the service recipient, the interviewer asked, so why do you think it took you a long time to go to the hospital? It just felt like too much energy? My assumption. And then the service recipient said, well, no, it's not the energy. Just I wasn't feeling good enough. People were judging me and not caring about me. And then the service provider, in kind of a common vein, in a different conversation, was saying, so service recipients and providers are both accepting and honest of each other, right? So she's describing a situation that she experienced, an example of equitable care she witnessed. He died in his sleep, and the people that were caring for him were brokenhearted because he had opened up to them and they had opened up to him and they loved him. I know that we toss that word around in palliative care, but they actually loved him, and they showed him that love, and he did the same back. It was such a profound example of what can happen when people just consciously lay their judgment aside. And the second one is maintaining reflexivity. Service recipients saying, I wish I could just make service providers realize, like, for sure, all these doctors don't even know what the hell they're doing. They could just stop being so judgmental. And then service providers saying, we all have biases and that is fine, but it's being aware of those biases and how you show up. I just don't think people have the experience and nuanced understanding of equitable care. I don't think anybody is trying to create more problems, but I think we are complicit in the system continuing to create a lot of inequities by not being aware of how we show up, because individuals are our healthcare system. So just kind of showing that in both cases, they're really orienting to that relationship network, kind of creating a relationship in that care provider space, but also challenging the systems of power side as well in doing that work. So the other 2 sub-themes, respecting autonomy. The service recipient who had meticulous end-of-life care plans said, I think it would just be health equity, would be if they would just respect my wishes. I want them to respect my wishes. I have palliative end-of-life care plans. he just said plans, and down to the very last detail right now. And then the service provider said, health equity in my work is about respecting autonomy, not taking a paternalistic approach, and really allowing people to have that information so that they can make their own best decisions of how they would like to determine where their life would go. So that first sub-theme illustrates how service users spoke about it being important to them that their personal wishes are respected. This person had every detail planned out in terms of how they wanted their end of life to play out and had not always experienced that respect for their wishes with healthcare providers. While it may be easy in cases where the healthcare provider agrees with the decisions and wishes of the service user, where it becomes less straightforward is the misalignment between what the provider feels the person should do or should want because you care for the person and their health versus what they actually want. This takes the skill of respecting autonomy of this person, despite feeling that we may know what is best for the person. Relatedly, the participants spoke about providing holistic care. So the physician was not paying attention to what I was saying. This is a service recipient. He just skipped right past the important parts of my life, like my brother passing away and how that affected me. How could he help me if he doesn't listen to me? And then the service provider says, I think health equity is part of palliative care. Palliative care is about prevention and relief of suffering holistically, whether it's spiritual, social, physical, psychological, or existential. Therefore, it's being aware of the whole person, including the inequities that they're experiencing. So these quotes just show that equitable care is for the whole person. They're not just medical symptoms. The service user here provides a good example of how they felt that their service recipient here provides a good example of how they felt that their physician was not paying attention to parts of the individual's life that were important to him. Also reminding us of the first theme, which speaks to showing up in ways people need. The service provider in the study who said this quote speaks to the importance of being aware of the whole person and that suffering may involve aspects of life that are beyond just physical. So the theme ties well into that relationships and network sphere of influence from the health equity framework, putting emphasis on that social, relational aspect of service provider, service recipient interactions. But we sometimes forget about the importance of, and perhaps may not have the capacity or skill to build relationships with clients or patients, but both recipients and providers bring up the pieces of care that tie back into relationships between providers and recipients, including autonomy, including holistic care, and challenging those systems of power, despite the constraints that we all experience with the wider system, especially in Alberta. Last one is engaged presence, and they have two sub-themes. So establishing personal connections and taking time. So the service recipient here for establishing personal connection says, for me, it's trust. I trust them. I trust the palliative and end-of-life care team. I trust everyone up here, especially so-and-so, because they don't lie to me. That's the thing I don't want. I don't want to be lied to. And the service provider said, their vital signs are there for everyone to view on record. Their medical histories are there for everyone to view, but who they are is lost in there. What was important in their lives? What are the things they're most proud of? What are things that they remember that help them go through this difficult time at end of life? So the participants spoke about establishing personal connections as being important in providing equitable palliative and end-of-life care. For recipients, this looked like having trusting relationships with their service providers. For providers, it recognized how institutional and cold systems in place can be. There's a responsibility to be sensitive to the person that's behind the statistics and case files that service providers have access to. Much of the humanity of the person can be lost in these files, and at end of life, these are the things that are often important and on the top of mind of individuals going through life-limiting illness as they reflect on their lives. One thing I learned yesterday, and that I've heard of a couple of times, is this idea of a secondary chart. Not sure if any of you have heard of it. Anybody not? Yeah. And so that kind of is a way to combat that, and I'm really interested in looking into that, but I haven't yet. Anyway, and then the second piece is taking time. So a service recipient is, communication could be better with doctors, mostly because they don't really give you any time. You don't get much time when you go there. I understand they're busy, but take an extra minute or two and talk. This one's a difficult one when I'm reading it because I think about what a luxury time is for people on the front lines and how we're expected to do more with less. So I saved it for last for a reason. So the service provider said, health equity is time. What I mean is that if you're going to make things equitable within the healthcare system, it requires more time given to people and to certain populations. That's the challenge for healthcare because it's often seen as a finite period to do a finite thing. So for a complex psychosocial setup or poverty, it takes more time to navigate. More time is seen as more money. Leaders hope that this population just fits in the system. I don't feel that health equity is well understood, possibly because it involves cost, but I think some people are frightened by that. However, what I think you gain in the upstream, you prevent in the downstream. So taking time with people one cares for is a way to build a relationship and stronger network with people, but also challenges the systems of power in healthcare that tend to focus on efficiency, which can be in contrast with the capacity to take time with people. The service recipient explains that they were not given the time to communicate their needs to their physician and not needing more than an extra minute or two. The service provider quote echoes this sentiment, describing how the structure of healthcare is based on certain interventions or services being allotted finite amounts of time, which takes away from equitable care. This person explains that for people experiencing complex challenges, it takes more time for the service provider to navigate, and it should be recognized. And that just doesn't fit in our model of care currently, because what they surmise is due to cost. However, recognizing that perhaps taking more time might be more cost in the moment, they also state that it can prevent costs by taking time to address the issues properly and not having them have to come back time and time again. So in conclusion, with all sub-themes mapping onto that health equity framework, focusing on those top two spheres, what I feel like we can take away is that equitable care in the context for palliative and end-of-life care for people experiencing homelessness very much focuses on the social rather than individual levels of intervention. While social ideas are not new, we still have far to go in understanding how we can use this information to make change in our practices. All our themes add social practice components to what we often operate under in traditional biomedical care models. But again, if workers aren't being taken care of, the vicarious trauma can't be ignored. The other expectations, these barriers that the workers themselves, it's that systems of power place where the real change needs to happen. But also recognizing that really good work is being done and these relationships are being built despite the constraints should not be a reason to then put more onto individuals that are making it happen despite their own deterioration, for lack of better words. 2, these social considerations challenge power dynamics between service providers and service users that are inherent in the way our systems are structured. The health equity framework helps us recognize how relationships and networks between people, formal and informal, are impacted by systems of power and shift our gaze to how practices can be more equitable. Of course, this happens in the context of a person's response to their social and economic conditions, and if we commit to more equitable practices, starting with these 3 components to care, we can shift these spheres of influence from their health inequity promoting tendencies to health equity promoting tendencies for this group. This study complements a wide knowledge base about the barriers and challenges, but it adds a bit of a practical lens coming from people with lived experience of being cared for and also the people caring for them. Limitations to that are that we only spoke to people being cared for. There's a whole group of people not being cared for, and so what does equitable care mean to them? So caveat, limitation. And then also, while all 4 spheres of influence are relevant, drawing attention away from individual factors towards relational and power factors help us forge ahead in practical ways and hopeful ways, hopefully, of creating more equitable care practices and environments. Relating the findings to a health equity framework, we hope helps us think about things in nuanced, interacting ways while using a practical approach as best as possible. Sensitivity to language and concepts that over time help us mitigate losing meaning or being interpreted wildly different among practitioners. I'm practicing health equity might mean something to somebody. We're trying to kind of create language and create description around what that looks like in real practice for people who are doing this work outside of the mainstream health system. You might look at this and think, yeah, that's harm reduction, that's trauma-informed care. We steered away from those concepts in understanding health equity to ensure we didn't dilute our findings or change our findings with more terms that have gained traction to the point of being potential buzzwords. Really wanting to ground the findings in tangible actions without categorizing them in terms that have already come to be kind of preconceived ideas. So this project hopefully offers a pathway forward toward equitable healthcare practices and policies for people experiencing homelessness, facing life-limiting illness, and helping palliative and end-of-life care decision makers incorporate equitable care practices into public health interventions from the standpoint of people delivering and using services, and which we argue hopefully is a pathway toward creating more equitable care. If future research needs to understand and move towards seeing how intersecting statuses. So again, we didn't look at Indigenous groups. We didn't look at cultural backgrounds. That needs to happen as well, understanding that there's an entire lens there that's being missed when we talk about equitable care. So lots of work to do, but kind of just trying to get away from those big, kind of large buzzwords and getting into the nitty-gritty of the practice. Anyways, thank you so much. I appreciate your time, and hopefully we can move on to the next discussion. Yeah.
Thank you so much. I actually like the term practices as a short for policies and practices. Could save us a lot of time.
Practices.
All right. Our next presentation, we have 4 presenters. It's exploring innovations and opportunities to provide better healthcare for older persons experiencing homelessness. In no particular order, because I don't know the order, it's Jill Alston, Alicia Campbell, Lara Nixon, and Teresa Conroy. Welcome.
Just gonna bring us. Okay. So as we get these on the.
Did you hit present?
No, I did not. Sorry. So I'm Jill Alston. I'm a geriatrician at St. Mike's in Toronto. A very inspiring and very applicable to the work that we're doing. Learned a lot. So thank you very much, Courtney, for setting a wonderful stage for our talk here today. I'm just going to give a bit of a preamble just to, set the stage on the issues of aging and homelessness, and give a bit of a background. Sprinkled in there will be a bit of the data from the outreach, geriatric shelter outreach program that Alicia and I are part of. And then we will dive in a bit more into 2 different programs, and also get to hear from Teresa Conroy as well. So our objectives, so by the end of our portion, we hope that individuals in the room will be able to describe the intersecting personal and structural vulnerabilities contributing to homelessness in older adults, including mental and physical health status. Discuss existing Canadian innovations in shelter, supportive and long-term care for older adults experiencing homelessness and complex needs, and develop strategies to care and advocate for older adults at risk of and experiencing homelessness within local context. And hopefully I learn from individuals in the group in terms of identifying priority areas for service and system change. So just by way of introduction, Lara Nixon is here at the end of the panel. She's a family physician and community-based participatory researcher from the University of Calgary. Teresa Conroy, right here, is a peer researcher, peer support worker, research community liaison at University of Calgary. I myself am a geriatrician and am part of a geriatric outreach program to shelters at St. Mike's Unity Health Toronto, and work with Alicia Campbell, who is the outreach counselor coordinator to the program as well. And then, of course, Courtney needs no introduction after we were all very inspired by her presentation. So I'd like just a bit of a way to get some interactivity and also learn from the group here. So who here works in healthcare? Okay. So probably got a mix in between where we're coming from. So again, I'm framing this coming in as a physician and hearing so much. I learned so much from presentations like Courtney's, where I'm actually hearing about what do recipients of the care actually perceive and what's important to them. So thank you. So who knows if their city has a specialized geriatric outreach for individuals experiencing homelessness? Okay. My city has shelters that are designated for older persons who are experiencing homelessness. Okay. And if people are brave, maybe you could shout out the city that you are coming from. I'd be interested to know outside of Toronto where things might exist. Pardon? Maple Ridge, BC. Toronto. Okay. Abbotsford. Montreal. Okay. So, excellent. My city has a long-term care home that's designated for individuals with previous experiences of homelessness. Sort of. some of these. And then my city is palliative care services that are easily accessible to persons who are experiencing homelessness. So like very few hands here for the long-term care and palliative care. So I see a hand at the back.
Can I add one thing to that?
Absolutely.
We're in the process of building in Ottawa a supportive housing for people who are aging, but looking at not just aging by age, but premature aging.
Absolutely.
And supports for that, and we're just starting that.
Oh,
I
that's.
don't see that up here.
Oh, yeah, excellent, thank you. Yeah, so, and we know that housing in and of itself, not just the affordability, but also the accessibility and ability to age in place is really important too. So, which of the following statements is true about the number of older adults who are using shelters in Canada? So I'll let you read through the A, B, C, and D. You'll be tired of my voice by the end. And then I'll just get people to raise hands for the different prompts. So who thinks that it's A? Okay, what about B? Okay, C or D? So yeah, whenever you're asked something where it's the most extreme, often that's the right answer. So yep, so B, it's increasing at a rate greater than what can be expected just from the aging population on its own. And there's a projected significant growth in aged homelessness or late life homelessness, especially in those who are 65 and above. And certainly we'll also talk about, you know, the age cutoffs too, and the 50 to 65, where we actually do consider people as older adults experiencing homelessness, just because of what was sort of mentioned, that accelerated homelessness, that, you know, the increase of aging that differs from what we, you know, determine as chronological aging. So who is experiencing homelessness in late life? So on the last point in time counts in Canada, and yes, there's flaws to the point in time count data, but we know about 30% of individuals experiencing homelessness were 50 plus on the last PIT count. And when you actually look at, well, who are the individuals? 50% had experiences of homelessness for the first time prior to 50. But we also know that there's a big increase in the amount of individuals who are actually experiencing homelessness for their first time in later life. So 50% had their first episode of homelessness after the age of 50. And I've put here, like, please don't share or tweet. This is our preliminary data from our outreach program. But we know from the individuals that we have seen in the outreach program that over half of the individuals that we are seeing that are being referred to us to access specialized geriatric care have actually had their first experience of homelessness after the age of 50. That's over 50%. The no are people where it was clear for the data extractors that they had earlier experiences of homelessness, and the other roughly 30% of individuals, it just wasn't clear. So my notes were not clear for the people who are extracting the data. So need to work on that. Again, just to put into the growing population of individuals who are experiencing homelessness in Canada in late life, they were the only age group who had increased use of shelters. And again, it's aging out of proportion to the aging demographic. And this is not just one city. This is something that we are seeing across Canada. So the take-home point number one, older adults experiencing homelessness is increasing, and this is actually partly driven by individuals who are newly vulnerable to becoming homeless for the first time in late life. So I'm not gonna, most individuals in the room are more expert than I in homelessness, so I won't talk about the factors that go into homelessness itself. But I will sort of point out some of the things that might put an individual who is 50 plus into a heightened vulnerability to becoming homeless for the first time in late life. When we think about those structural factors, we know a lot of individuals are adjusting to a fixed income for the first time, and really with our current cost of living that is insufficient to meet daily needs. And we have an increase in individuals who are older, who are in core housing need and are increasingly precariously housed. We know that ageism plays a factor, in terms of rent applications, jobs, There's obviously systemic racism and other earlier life experiences that have lifelong effects. So those earlier lack of opportunities, lack of opportunities for economic stability, education, employment, that impacts our financial security near the end of life. It impacts our interactions with the healthcare. It has lifelong effects that carry throughout aging. And of course, as pointed out from the back, we have a lack of housing options that actually allow individuals to age in place. So it's not just a cost issue for housing, it's also, does my environment actually suit my needs anymore? And there's a huge lack of an in-between long-term care and housing that requires an individual to have the cognitive, physical function to be able to maintain their independence. When we look at our systemic failures, lack of long-term care, home access, and it's not just the overall system strain, but also the ability to access long-term care, which we will get into, and long-term care that is suitable towards the needs to individuals with experiences of marginalization throughout their life, strained and fragmented healthcare and social supports. And when we think about the individual factors, we know that individuals as they enter late life are at have higher rates of social network breakdowns, the loss of a spouse, for instance, and especially too, we see a lot anecdotally the individual in whom their partner died, and then that income, where they required two incomes to pay for the absorbent housing costs in whatever city they're from. Now they can't afford housing, for instance, or they lack that caregiver who can help them navigate the healthcare system. Health status changes become more common in late life. And then things like dementia, mobility issues that may hinder the ability to live independently in, regular housing can start to impact how an individual can maintain their housing, especially if we're lacking that systemic and structural safety net around an individual. So the more structural factors, systemic failures that we have, the more fragile, more vulnerable an individual becomes. And you need less of those individual factors to become homeless if we do not have those safety nets. And if anyone is interested more, I can't put it as eloquently as Margot Kushel, but she's a researcher in the United States who does a lot, and there's a very great podcast, so I'll just note this here. I'd just like to highlight some of our data. 96% of the individuals that we have seen within our program are single, again, highlighting that social network and how important they become in both as we become older and increasing the vulnerability to homelessness. And 50% of the individuals that we've seen were first-generation immigrants. So I just wanted to point out with a case to sort of point out these unique vulnerabilities. So we've got an 88-year-old man, retired lawyer, widowed with no children, socially isolated, living in a basement apartment. He actually has a diagnosis of dementia. He is on long-term care home wait list, and this is some data have been changed to protect the identity of this individual, but completely based on an individual that we have seen. He's evicted for hoarding, missing rent, and goes to the emergency department. From there is discharged to a central intake shelter. So think of it, someone with dementia severe enough to be on a long-term care home wait list, interacts with healthcare, and discharged to a central intake shelter. And I think doesn't take anyone into the room to understand the vulnerabilities that individual is going to experience navigating the shelter system. So here we can see those different levels of vulnerability that have accumulated to increase that risk of this individual becoming homeless for the first time in later life. And again, I'm focusing on the vulnerability to homelessness in late life because I know everyone in this room is probably more expert than I in understanding homelessness across age groups. So take home point number 2, causes of homelessness in late life are complex. They're intertwined and influenced by our earlier life experiences that carry over and have a lifelong effect. And vulnerabilities to homelessness may increase with age as our social circumstances and our health changes and geriatric syndromes emerge. So how do older persons experience homelessness? We know that there's longer inpatient stays in terms of health outcomes, increased ED visits, total higher hospital costs, higher mortality. And when we look at, there's a recent paper where they looked at individuals with late life homelessness, and there's actually a higher mortality in those who actually experienced homelessness for the first time, greater than 50, probably because of just how that resilience that may have been built up in previous experiences. Often it might be an acute health change that has led to the new homelessness, and there is a heightened period of vulnerability. From our program, 58% of the individuals that we saw were age 70 and above. About 60% had diagnoses of cognitive impairment. And what really struck out is that a lot of it was unidentified. So in individuals who were seen by Alicia, myself, and then in whom we did the geriatric assessment, we picked up that cognitive impairment that previously was unidentified. And we know that 70% of the individuals that we saw were actually met the definition for frailty. So we know older adults experience accelerated aging, higher rates of geriatric syndromes, and are at higher risk of poor health outcomes. And then we look at how do we actually navigate shelters, navigate the experience of homelessness. We know shelters feel unequipped, right? These are not healthcare institutions. It's not a retirement home. It's not a long-term care home. But yet we have individuals with very high complex needs, functional needs that are being sent to shelters. And when we talked earlier, when Courtney pointed out, and something that we see, if systems are unequipped, it can lead to those individuals who are providing care to becoming burnt out. We all want to do well when we go to our jobs. We all want to feel like we're helping, and it's really hard when you are not given the tools and resources to help. So this is data actually from BC. And I haven't found anything similar across work across in other sites across the country, but certainly anecdotally rings true to the work that we do. Exiting homelessness, true or false? So older persons using shelters have shorter shelter stays than their younger counterparts. What do we think? Yes. So true? Raise of hands, true? False? Again, when it sounds the worst, it's probably the right answer when it's talk like this. So we do know that older adults have a harder time with navigating. Why is it not going ahead? Navigating exiting homelessness and having a successful transition out of homelessness. And a lot of that is because we lack a lot of appropriate environments. There's a lack of in between long-term care, regular housing, and then there are barriers to accessing long-term care when it is needed. And we've talked about the ability to access things like palliative care and hospices. So I won't deliberate on that more, other than just to say when we transition from shelters, it requires addressing those very factors that contribute to homelessness, but we, again, do not often have those services and supports and the ability to do so. So again, the formatting on this went wonky from Google Slides to regular PowerPoint. But again, trying to capture visually, the numerous issues at hand when we try to tackle like the major overlying issue of aging and homelessness. Okay, so as we go through our next round of presentations, when it comes to the Q&A, hopefully we'll have ample time for that. We'd also like to hear back from the group, what themes are emerging across different settings and issues in terms of understanding late life homelessness and complex health needs. What are the challenges, and then what are our opportunities and solutions in our current strained systems? So I've spoken enough. I'm now going to focus over first on Teresa Conroy, who is graciously giving her time and her expertise as a peer researcher. We heard, again, Courtney pointed out that it is so important when we're implementing things for change that we hear from individuals with lived experience, and that's how we learn to provide better. So thank you very much for your time, for inspiring us, and she'll talk about her experiences and also her experiences of being a peer researcher. And then we'll follow with some of the programs that we have implemented.
Thank you, Jillian. Good morning. So I spent about 6.5 years on the streets of Calgary. If somebody had told me that I was going to end up homeless, I would have probably laughed at them. It was a soccer coach and a mom and an advocate in the community. So some of the things, one of the things that that impacted me the most was the amount of trauma. I never really understood. I struggled with some of the behaviors I saw on the streets, and how actually dangerous they are. I had a woman actually break a pipe and stab me in the head. And of course, I wasn't going to go access services because, number one, I was terrified of the woman. She'd been charged with murder in Calgary for pushing a kid off a C train. So it was a lot of really scary. So I did not stick around in the general population. I kept to myself. I did not want to form any friendships because I noticed that these folks attack those folks, and so I thought it was safer to walk alone. People thought I was brave. I thought I was smart. Anyway, so yeah, I didn't access services, and when I finally had enough, I heard my daughter had come out to try and find me, and that's actually when I went into to try to get some help because I was really, really struggling. And that was one of the reasons actually why I ended up being homeless in the first place. Was my husband had taken the kids and moved to a different province and wouldn't allow me to talk to them. And I started using substances to cope with the pain. So I have over the years seen so many things, especially when it comes to accessing services, not just for myself, but for other individuals. And I'm very grateful also for the opportunities that I've had in my life to be able to put my life back together. And I sought out so many different resources. I had multiple people from different professions, mostly in the healthcare system that were able to give guidance. I had a psychiatrist who suggested I go to CMHA and be peer support. So he did a letter up, a referral. I used to pop in there all the time and give them a little progress report because I didn't have a self-esteem. I didn't have self-worth. None of that. And that's what really makes it impactful is I know what someone's going through because I've been there. I understand it. Places that I would choose to go sleep or hide, that hiddenness in the homelessness was to keep myself safe. Because quite often you get jumped, robbed, beaten, raped, and you lose count. And then you don't matter. None of that makes... so trying to figure out how to navigate the systems, I took everything that was offered to me and more. I sought it out. And because I would go into resource centers, they'd say, well, here's a recovery coach. The recovery coach would do a referral to a psychiatrist. The psychiatrist would do a referral to... And every single thing that they did, and I even sought out more, and I still do to this day currently, right? I'm always trying to improve and to never go back there. I went to 9 different treatment centers. I wasn't a one-hit wonder. I got some clean time in for about 1.5 years, and then I went back out again because I wasn't dealing with the stuff that happened as a little child, much like what Guy had said this morning. Loved that, by the way, it was great. And so... just really, really grateful because I was probably about 3 years clean before I started to recognize that I was the problem. It wasn't everybody else, but I was a victim for a long period of time and really angry because I didn't know how to cope. My parents didn't know how to cope, so it's looking back on them and learning about them and what their lives were like. Quite often when I was on the streets and I ran into somebody who was difficult, I would think to myself, consider the source, rise above and let it go. And what I mean by consider the source is, what's their background like? Did they have a mom like mine, or did they have, my dad drank. My dad's going to be 5 years sober in January. Good for him. So I've been the catalyst for change, but it's really due to a lot of the help in the systems and services. And then when you do, you can go back and help so many more people. And I mean, I found my niche in life. I always wanted to do that as a little girl. I wanted to have like peace rallies and stuff like that. So it's kind of ironic. I had to go through some really horrible stuff in order to do that for other folks. Some of the things that I've noticed over the times is I was working at the drop-in, and there's a lady that came in and she was a senior, and I wanted to give her a bed because it was empty in the back. And they were like, no, we can't do that. So I had to put a mat on the floor for this woman who was like 79 years old in the hallway. And she'd just come into the shelter, which is a really scary thing. There's so many people, there's so many different personalities. And I remember the don't stare the bear in the eye. I remember thinking that. I'd keep my eyes down so I didn't like, what are you looking at? Lots of confrontational behavior. And it's really difficult to navigate, not just that, but the trust. People don't trust. I helped another individual who stayed out at the airport. He'd been in the army, and he was really traumatized apart from what happened in his background. So that's really how I help people, is by finding out where their story started. And then building the trust with them. He came in one day, he was so mad at me because the housing they were going to put him in had a lot of cameras. And he didn't want that. So, he come into the source and he's yelling at me, what are your credentials? Which was a little embarrassing because I've worked really hard to try to gain respect from people. And I felt really diminished in that moment. But I took him aside and we had a conversation, and I said, if I was yelling at you, how would that make you feel? So it's taught me how to be kinder, more compassionate, and really grateful for some of the opportunities that I get. I'm kind of rambling now. There is another project that we were working on, and Laura, I think, is going to come up and talk about that, and then I can share a little bit about the peer support I did with that, and not about me. It's not all about me. So thank you.
Okay. Let me see what I can do with this.
It's this one.
Okay. And then,
I think you just got to present. I think you go to slideshow. Oh, yeah. Oh, no, you got it.
perfect. Okay. So before we go to Lara, we're going to jump into a little bit more about what it means when Jill was talking about the outreach program. What is that program? Let's see here. So it is an outreach program that goes to 2 shelters and 1 supportive housing building for those who are in modular housing that has previously lived in the shelter and is exiting the shelter. The aim is to provide comprehensive geriatric assessments. This is actually one of the locations, what it looks like. It was previously a motel, and the other aims is to really help with capacity building as well, with the staff, with the people inside, with other community partners that we might be working with. The population is anyone who has been in the shelter in the settings that we go to, usually about 50, 55 and older. Sometimes we might see someone a little bit younger, but that's just because their physiological age kind of presents as that who is like 70 years old. And our team is both myself, Jill, and we have a second outreach counselor that we just was able to expand to. So our program evaluation component is also a part of how we're getting the data that Jill was able to present. And with most of the slides, when it does talk about specific numbers, I just want to preface that with preliminary data, don't tweet or share, but it's going to be up there for you to kind of look at as well. But our clinical program, it starts with referral triaging. What that looks like, someone sends a referral, I do the initial assessment, the outreach counselor, we liaise with the staff, kind of collect that collateral information to see a whole picture of what the person is like, kind of to also build that trust while we go in, kind of what Teresa was mentioning earlier. Then the assessment comes, comprehensive geriatric assessment. Jill comes in. I usually joke around with the individual and say it's when she comes and does the doctor stuff, because I am not a doctor. My background's in social work. So we kind of build the stage. She comes in, completes the geriatric assessment, and it will know any recommendations that might be able to enhance the individual's care while they're in the shelter and continuing on to wherever housing destination would be after the shelter. Then the implementation comes with the recommendations. All the recommendations go to not only just the staff in the shelter, but the physicians that are in the shelter. Some of the shelters that we go to in the housing buildings, they do have a lot of comprehensive care. They might have they have physicians there, or nurse practitioners, they might have neurologists, they might have a psychiatrist, they might have occupational therapists, people to kind of round about the care for the individuals in the locations. But that's not necessarily the case with all the shelters that are out there. And it's just the, I guess, lucky or fortunate too that we go to that does have that care, that we're able to provide such comprehensive care. And then it also includes a follow-up. So our program does also have the evaluation component with the qualitative interviews with the staff, the patients, the individuals, sometimes with the service providers in the building to kind of see what kind of care we're providing and is it beneficial and how can we enhance it. It does chart reviews for the qualitative data, go through the stats, the age, the demographics, first time experiencing homelessness, connect to physician, a lot of information. And the chart reviews were a lot that from the data that was presented is from June 2020 to September 2022. And then the capacity building is really to enhance the care for the older adults who are experiencing homelessness in the shelter. And that's really where we go in and we provide e-modules, presentations, just connect with a lot of supports that would help prepare the staff who might not have that geriatric specialization so they can see what might be the trends, what might be any of the symptoms that are prevalent in older adults experiencing homelessness to kind of enhance the care and not have anyone fall through the cracks while they're within the shelter system. So as you can see, for the program evaluation, there are the barriers and facilitators. We're going to go through some of that, where we do have the qualitative interviews and the chart reviews. A lot of it's just to extract the data. We do have a lot more than 100 participants now, but this was when the information was pulled for the chart reviews. And then we are looking really for what the impact is. Let's see here. So what we've noticed with some of the barriers that we were interacting with, some of the reluctance of individuals wanting to engage with the healthcare, not only necessarily the patients, but also the staff, trying to figure out, well, what's the take home that they can have? Is it enhancing to the amount of work that they need to do, or is it something that's going to actually build the support for the individual and the staff around? And then for the first 2 years of the program, we didn't have an outreach counselor. So it was new to the program. I'm new to the program.
Physicians are awful at organization of programs.
Yeah.
So it was, you'll see that there was a lot of improvement after Alicia came on board.
So then I was hired, and we were able to collect a lot of that data for the chart, the extractions, so we can get the qualitative data. We're able to have one-on-one contact with the person. I was a point person for a lot of individuals in the shelter and the staff. And we did expand recently to a second outreach counselor to kind of help with the presence and the facilitation and kind of be the bridging person for navigating the healthcare system, because it's absolutely very complex. And we have good facilitators, not all negative, but there was a lot of good buy-in from the staff at the shelters and the individuals when at least, and this is anecdotally from my perspective, but one of the themes I kept getting was, I don't know who to turn to because I'm physically in the shelter and I don't want to have my stay impacted by any information that I'm giving you. So I would be able to walk in and say, I'm not the shelter. I am a middle person. You can talk to me. We'll see what we can disseminate to whoever. And the expertise and availability of the geriatrician, Jill, always available. I don't know how she does it. So we noticed with our impact, we were able to help identify and address complex and comorbid health concerns in physically and socially frail older adults, age 55 and older. We were able to help with transition residents to more appropriate placements, because one of the biggest impacts with the comprehensive geriatric assessment is the geriatrician would have, this would be the most appropriate destination, maybe long-term care or maybe supportive housing, or maybe this person's able to live independently on their own. And then one of the impacts is the enhanced knowledge and confidence in addressing the needs for older adults among shelter staff and healthcare providers. Because even though we do have the shelters available, there's no say that this person is going to specialize in older adults. All right, and then we already went through the impact of the outreach counselor. We have a middle person that's not just, that's kind of a bridging, not necessarily a healthcare professional, but kind of an allied healthcare professional. And then more to the long-term care mapping. Once again, preliminary, please don't tweet or share. And I do want to speak a little more quickly so that we have some time for Lara and questions at the end. But what we were able to do with this program, we were noticing that there was a gap of individuals accessing appropriate health care and accessing appropriate housing. And one of the biggest things that we were able to complete was long-term care process mapping, where we were able to talk with the shelters, the individuals, and see what's really happening. How are you accessing this? Do you know how to access it? Do you know how to appropriately display yourself so they are able to know, whoever they are, that you need long-term care or that you need additional support that's more so 24-hour care. So what that looked like was focus groups with 6 shelters, and then one-on-one interviews with staff and residents, and then the chart reviews. So once again, preliminary, do not tweet or share. Getting the theme here, but it kind of produced this. Some of the shelters, they didn't know how to access it. They didn't have a point person, a care coordinator in Ontario is what we call it, to access the process for long-term care. And
Can I just point out one thing?
Yeah.
So on that last one, this was a shelter that was designated to older adults, so they only took individuals 50 plus, and they weren't able to successfully get one person an assessment done. So they would put in the request for an assessment, and just because of those barriers, they just were not then getting the assessments completed. So it's not just a resource thing, there are barriers along the process steps, which actually now I'm taking the thunder.
Which is
but
okay,
I just really wanted
because-
to point out, it's pretty shocking that this is actually a place designed for older adults.
And this came from a lot of devastating news, because we were following individuals throughout their time at the shelters that we access. And this came out, I think, kind of after we noticed that one individual waiting for long-term care, very cognitively impaired, couldn't even navigate their way back to the shelter, to anywhere on their own. They died. And just seeing that they weren't able to access a supportive environment that would have been best for them. They were cognitively impaired to the point where when they were previously in housing, they had geared to income housing, and they couldn't get there because they didn't think they had money to have housing, so they ended up in a shelter. So those are things that we realized when we were doing this. Once again, preliminary data, please do not tweet or share. But we noticed that people aren't accessing the supports appropriately, what they want, what they need while they're in a shelter. And that was what we identified for one of the barriers. Barriers with the shelter is it's not 24-hour care. It's not a locked facility. They're able to leave. They have difficulty accessing primary care, and not all the shelters have the primary care embedded in with their programs. And limited information sharing, because social and medical sometimes works in 2 different silos, so knowing what's happening 24 hours all the time, it's not something that can effectively happen at a shelter. And then there's high rates of rejections, what Jill mentioned about longer wait lists because it might be substance use, might be because of the location. And ultimately, a shelter is deemed as an appropriate place to wait long-term care. It's not it's deemed as just long-term housing when you're looking for long-term care, instead of the quick, temporary, individuals are not getting the supports that they need. So the facilitators with this is that in collaboration with in-home services, the healthcare workers and shelter staff, and access to geriatric services. So they do have a good collaboration network for the ones that we were able to go for the asset mapping. For most of the shelters, there did have a home care coordinator designated to them to kind of help facilitate that process, especially weekly or bi-weekly. And then they did have the support from the hospital. All right, so why does this matter is because conditions deteriorate within the shelter and it stretches shelter capacity, so it impacts other individuals. What that means is that if someone's waiting at a shelter for long-term care, they're not going anywhere. They're waiting for long-term care. They're not going off to housing or the hospital to wait, they're waiting there. And there's lower resources and opportunities to make access more equitable. So what that looks like, we're not looking to change with this side study. We're not looking to change anything about accessing it or adjust the algorithms. We're just making sure that there's a voice to be heard that people can't wait in the shelter system for long-term care because it's not the supports. They are waiting there and they're not having access. So why isn't that looked at like a hospital stay, right? For our program, just one last thing, we do want to acknowledge the outreach counselor that's not here, Noah, really great. Our research coordinator that really pulled all this together for the stats and distractions and the interviews, Yasmin Garad. Parnika, who was Jill's summer student for this entire program for the long-term care sub-study, and the principal investigator, Dr. Sharon Strauss. And also, we like to express our gratitude to the Slate Foundation for supporting this work, being able to provide us with the ability to look at what's happening within the shelters for older adults, and just the site staff and the participants, the residents at the shelters for the contribution.
Okay, I can't find this.
I don't see it either. Can't escape.
Yeah. Something is.
There it is. You got it.
There we go.
Thank you.
I lost the last
Yeah,
time.
it's not this one. No, I need to go
on the other slide. Okay, thanks so much. Yeah, you're great. Thank you.
There we go.
Just this button at the top.
Thank you. Good morning. I'm Lara Nixon. I'm a family physician researcher, mom, partner, auntie of Scottish and Ukrainian descent on Treaty 7 lands in where I live, work, and play for the last quarter century. Really grateful to be here with you today. And very excited to share with you a bit about a program of research that we have been developing with our community in Calgary, particularly about more integrated approaches, holistic, balancing social and medical approaches to our work. And we've had the really good fortune of a lot of support, not only from financial and organizations, but the community partners in Calgary, as well as a core group of people living in Calgary, who some of whom are still working with us today, 7 years later, and really grateful. And Teresa's here with us today. I'm wanting to tell you about a specific setting we call Harbor House to just protect people's privacy. But to give you the quick skinny on this, this is quite a unique setting in our landscape on the prairies.
It was opened in 2005 to help people transition out of the shelters who weren't able to secure housing elsewhere. They intended to be transitional, but quickly realized that that wasn't possible. There weren't options to transition to, so they became supportive housing, and were funded essentially the same as a site that was just providing shelter. And so this is part of the ongoing story here. Indoor smoking in our city is very rare to be supported, and having an elevator was a really excellent thing. There's about a third of beds are in dormitory arrangement that the men cycle through, and about half of people stay in those beds. That's their preference. It's slightly reduced cost, and some people prefer that. And then the rest are private rooms with shared or private bath. I've had the good fortune to be an outreach clinician in that environment for about 15 years. And they had really robust social work supports on site. And prior to the terms becoming vogue, they were offering supports for people to manage their alcohol and tobacco use, pace their use, ensure they didn't lose access. And then really robust partnerships with the health authorities, home care staff. The for-profit vendor actually found a lot of value in having a more dedicated pool of what we call HCAs or healthcare aides, who would provide on-site supports as far as personal care, medication administration. And we had some nice partnerships with geriatric medicine for a while, and psychiatry would visit a small pool of people who were on a sort of community treatment plans. And this program, as far as the visiting health services from the community health center started in 2005, was very much driven by the nurse practitioners. As GPs, we started coming a half day once a month, and then that escalated as the complexity and acuity of people's needs changed. This is a little snapshot of, and this is based on the housing providers' intake data, just to give you a sense of the people's health and substance use statuses, making it quite challenging for them to secure housing elsewhere. And I just want to very briefly allude to a qualitative piece of work that I was lucky enough to work with Dr. Victoria Burns, who's social work faculty in Calgary now. We were really interested in what is it like to live and work in a congregate setting for older people that had a harm reduction policy. And that, if I could say, set of principles, which wasn't really formalized, we learned, but really facilitated the getting to know one another as staff and residents, which led to trusting relationships and a whole lot more acceptance of supports than we believed would have happened without that. And the long-term, like the lack of an endpoint, not being transitional, nobody being expected to go anywhere, although some people did move to other places, being really person-centered, just as we've heard from others, being flexible, respectful for people's choices and preferences, and these other partnerships. But what we did identify was there were people who were not accessing the level of supports that they, especially over time and more recently, and there was identified boredom and people really thriving during the summer when we'd have summer students from recreation therapy, psychology, sociology, you name it. They'd come and do all this creative, wonderful stuff on a total skinny budget, but then that would be gone after 3-4 months, and it would be a new group the next year without any kind of opportunity to learn from previous years. Always really welcomed, but the winter is long in our province. So I'll come back to that in a moment. We did do a cost analysis. This probably shocks nobody. If you take people, many of whom are in a long-term either psychiatric or acute care bed, and you move them out of that bed, you save funds. And so it's not rocket science. But we thought it was very interesting to be able to show these costs continuing to trend downwards in the 3 years after move-in for a group of people who are on an accelerated trajectory of aging. So that was what we wanted to share there. So we were able to convince Health Canada that harm reduction could be pursued through therapeutic recreation, and we proposed it as a co-designed and implemented and co-evaluated approach with the community there. These were some of our advisors and partners. They identified as a group as the exchange, emphasizing that exchange of learning and knowledge and ideas. And we launched just before COVID hit. January, gray line, January. You can see the nice climbing up of the programming and participation, and then plummet. And that was with the initial public health restrictions. No gathering, the dining room closed, we were delivering meals, et cetera, et cetera. You can see the program grew beautifully in that first year to better than 80% participation in the building, which we were quite excited about. And we maintained that in the second year with the 2 exceptions of our outbreaks and interestingly, you can see how between the 2 outbreaks, we actually dropped initially to below 20%, but then actually still maintained close to 50% participation because we switched. The team switched to one-on-one and virtual. We had half a dozen iPads, and they got really creative. And that gives you a little sense of the multidimensional activities. And these were all identified with the community there as these are things we want to try. And they did surveys, they did all kinds of data collection. We have this in review, and hopefully we'll have something to share in publication. This is the data I really wanted to show you. I should have actually shown you the self-reported health data. We just used a visual analog scale, but it showed the same thing as the reported quality of life. During COVID, in a setting that was really imposed upon by the public health restrictions, and we were able to demonstrate an improved quality of life and an improved sense of self-reported health for the people living there. And then the blue square, again, going back to the work that I'd done with Dr. Burns, we were told unequivocally, don't try and set goals in this setting. It's just another way for people to fail. This was the staff telling us that was their learning. We found when you were talking about recreational and leisure interests and pursuits, people went full on. And over time became, they shifted from physical goal setting and, I want to get stronger, fitter, whatever, to talking about social and cognitive, mental health and spiritual goals. And so it just was a really, we found this really compelling, and even more so what people told us about new confidence. This gentleman, didn't think much about aged care settings and thought they were going to be pretty boring. That was his expectation. And we were able to surprise him, and he became a real ambassador for us and continues working with us today in a different setting. We had people who had been totally fearful about touching a computer for fear they might blow up the world. And literally, they actually learned to navigate the internet, do email, etc. The increased sense of connection amongst the community there, and seeing people who had literally for 4 years of living in the setting never done anything but come down for meals, start to participate in social activities. And this sense of connection and peer mentorship was really quite compelling. And the staff remarked on how bringing in a bunch of small furry animals helped people to see how much they were more alike than different. And so better understanding for the staff as well about people as individuals, as complex, multidimensional individuals. Some even going so far as referring to the rec staff, so our therapeutic our rec therapist and the 2 recreation team, dedicated team members that we were able to support with this funding, as feeling like family, which we just kind of went, whoa. And the staff themselves just really feeling empowered and more able to connect with people wherever they were, being really individualized and flexible, but also keeping that eye on sense of community connection and development. For some people, that even went so far as to reconnecting with outside organizations and activities and programs. This is when so much was closed during COVID. So that's what we found, and I'm just going to come back to this in a moment. We applied a very wise model of care from that is strengths-oriented, and that's why I think we all felt really excited about this work, is we were able to offer these opportunities for positive emotions and fun and exploring identities or interests or activities and places that people may have never been. And what we saw or heard was that helped people to develop resources, both internal and connection with others and outside resources, that learning, which we started to see this nice cycle of this positivity and these positive experiences and interactions that we believe, although we didn't measure specifically, we measured quality of life and self-reported health, but we feel over time this would have been leading to a sense of more individual fulfillment and well-being. And so having the expert-led and the dedicated staff resources to do this work. This isn't an add-on, right? I'm a visiting primary care provider. I can't offer anything near to what I think this programming was offering. And the key of the collaborative co-design and ensuring that you were positioned as staff to really see, get to know, earn that proximity, earn that trust, walk alongside. Oh, maybe this would be of interest to this person, or they would just start to offer up, right, what was of interest to them in a multitude of different ways. So that's, if you are interested in this, our whole implementation handbook is available for free. So, thank you.
Thank you all for your very interesting presentations. I think we maybe have time for like one burning question. Otherwise, I'd invite you to reach out to the presenters individually. Is there anyone who won't be there? Okay.
Fantastic presentation, but I just want to ask Teresa, how old were you when you found yourself homeless? When did it start?
So for me, it was late 40s. And yeah, and then even after my 50th birthday, I got a year and a half in, and then I struggled. I struggled for probably another 2 years before I was rehoused. Saturday, I've got 7 years.
Go for it.
So the geriatric outreach program for UHN, is it specifically for shelters? Because I work in drop-in that we have many people, aging populations that are struggling in getting care, and we're finding ourselves really struggling to try to get them assessed or getting them support. They're refusing housing because of their unmedicated mental health, such as schizophrenia, so they're not going through the shelter system, and we're trying to support them, but we're finding they're falling through the gaps.
Yeah, so right now our criteria is like we're essentially just going to Seton House, Scarborough Village, and 540 Cedarvale. We do, are you at Haven?
I'm at Park.
Oh, okay, yeah, so, you know, get our info after, like there are some programs who will email us about particular patients and we'll try to squeeze them into my outpatient geriatric clinic, but we know the struggles is having the individual be able to like make it to the outpatient appointment. But that's the hard part. It's just 3 of us, so we're doing the best, but we do try, like we've made some exceptions if we've got like a free day to do a field trip, as we call them as well, so.
Yeah, and I think also, and just more
Project
on
Info
the,
too, yeah.
sending us the contact information, like, for the social side, sometimes, especially depending on my schedule too, I might be able to provide some social enhancement just for my assessment, but if it's like really getting to see a medical practitioner, like a geriatrician, then yeah, it would be sending the referral to the hospital.
Yeah, we should connect because there's also Project Dignify, which offers like outreach, case management, and geriatric psychiatry. And so depending on the catchment of the individual, they also might be a good resource. Yeah.
All right, I'm sorry, I have to close there because we have to make our way to the lunchtime plenary. Thank you again to our presenters, and please approach them if you have any more questions.